Welcome to the Pharmacology GIT Series with the Med Girl. Today we'll be discussing an important class of drug, that is the proton pump inhibitors. Come, let's dive in. So, what is a proton pump inhibitor? A class of medication that significantly reduces the production of stomach acid by irreversibly inhibiting the hydrogen potassium adenosine triphosphatase enzyme system, also called the gastric proton pump. Now, let's take a look at the mechanism of action. PPIs are prodrugs, that is, they are taken in an inactive form and only become active after they reach their specific target site. Each tablet has an enteric coating to prevent breakdown by stomach acid. The enteric coat dissolves, and PPIs are absorbed from the small intestine, entering the systemic circulation in the inactive form. And then they reach the gastric parietal cells through the bloodstream. The PPIs then accumulate in the acidic canaliculi of the parietal cells, where they are converted to the active sulfenamide cation in the acidic environment. This active form binds irreversibly to the gastric proton pump. It forms a covalent disulfide bond with the SH group of proton pump. This binding blocks the release of hydrogen ions into the gastric lumen, and thereby effectively blocking the final step of acid production. If you are wondering what a hydrogen potassium ATPase pump is, it is an enzyme found in the gastric parietal cells of the stomach lining, which is involved in the production of gastric acid. After its action, the drug is metabolized in the liver. In the cases of severe liver impairment, we might have to reduce the dose of PPI. What are the PPIs you know of? Well, we have omeprazole, pantoprazole, esomeprazole, lansoprazole, and rabeprazole. We use PPIs in cases of A. peptic ulcer disease, that is both gastric and duodenal ulcers, B. Sollinger-Ellison syndrome, C. in H. pylori eradication regimens along with antibiotics, D. gastroesophageal reflux disease, and E. in case of NSAID-induced ulcers. PPIs are generally well tolerated, but some may experience nausea, headache, abdominal pain, bloating, diarrhea. Prolonged PPI use can result in vitamin B12 deficiency. It can even decrease calcium absorption that can increase the risk of osteoporosis. Also can lead to hypomagnesemia and may also increase the risk of enteric infections by Salmonella, Shigella, Clostridium difficile. A few clinical pearls for you to remember. 1. PPIs are best taken in the morning before breakfast. 2. PPIs reduce gastric acidity. This may decrease absorption of antifungals like ketoconazole. 3. PPIs may enhance effects of warfarin, phenytoin, carbamazepine, and benzodiazepines. This may increase their plasma concentration and heighten the risk of toxicity. Another clinical pearl drop: PPIs have short serum half-life of about 1 to 2 hours, but their effect lasts up to 24 hours. Why is this? Because PPI irreversibly inactivate the proton pump, and for synthesis of new proton pump, at least 18 to 24 hours is needed. That's all for today's topic on proton pump inhibitors. Stay tuned for more videos in our Pharmacology GIT series. Don't forget to like, comment, and subscribe to the MedGirl 96 for more easy-to-understand medical learning.